Hey everybody, Dr. Becker. We are jumping into a really big unit now. This is 13 chapters worth of material. This is tough. This is really important material. I struggled with how to fit this in the best in the course. Just like cardiology, I really wanted to split it up because there's so much content, and it's really important to know. You know, when we think about prescribing, it's oftentimes, what do we prescribe? Antibiotics. So this is a huge, let's get rid of that. This is a huge topic and thing of discussion. I hope you guys do read or listen to your osmosis videos on this. They're very helpful, I think, of really walking through the information. One of the things that this chapter talks about is really understanding the basic principles of your antimicrobial therapy, because there's two main concepts. The first is your microbial susceptibility to the drugs, and like things like resistance and whether or not they're susceptible. And then the next part is how we use our antimicrobials and those other kind of concepts. So for chapter 70, we're going to kind of jump into it and talk about this in more detail. Bear with me on this unit. You guys, really, I would encourage you to dive into this really well, study it really well, really understand it, because this is such a cornerstone of what we do as practice as providers, is antibiotic type therapy. The first thing that your book, Laney's, really wants to make sure we understand is that there's a difference between an antibiotic and an antimicrobial drug. And the terms are often used interchangeably, but strictly speaking, if you ever were around with an infectious disease doctor, for example, there is a difference. We use them interchangeably, but there is a difference. An antibiotic is a chemical that's produced by one microbe and has the ability to harm another microbe. So under that definition, compounds that are actually made by microorganisms would qualify as an antibiotic. Whereas an antimicrobial drug is defined as any agent, natural or synthetic, that has the ability to kill or suppress microorganisms. But we use the terms interchangeably in this text. So first thing your book talks about is the selective toxicity, and that's defined as the ability of a drug to injure a target cell or a target organism without injuring other cells or organisms that are in intimate contact with the target. So if you had an abscess sitting on the skin, for example, we want to give drugs that are selectively toxic to that bacteria, but not to our healthy skin around it. So selective toxicity in terms of antimicrobials indicates the ability of that antibiotic to kill the microbial pathogen without causing injury to the host. So that is how antibiotics are valuable. If they did not have selective toxicity, then they would have no therapeutic utility. So there's differences in the cellular chemistry of the mammals and microbes, disruption of the bacterial protein synthesis and cell wall, and inhibition of an enzyme unique to the bacteria are the ways that we can achieve selective toxicity. So there are biochemical processes critical to microbial well-being that do not take place in mammalian cells. So drugs that selectively interfere with those unique microbial processes can cause serious injury to microorganisms while leaving mammalian cells intact. So disruption of the bacterial cell wall. This is a really important concept when we talk about like penicillins. Unlike mammalian cells, bacteria are encased in a rigid cell wall. The protoplasm within this wall has a high concentration of solutes, making osmotic pressure within the bacterium high. So if it were not for the cell wall, bacteria would absorb water, swell, and then burst. Okay, so osmosis does a really nice job explaining this with some imaging to really help you understand this idea. But it's this really, it's the cell wall that prevents things from getting into it, swelling and bursting. So we have several drugs, though, like penicillins and cephalosporins, that weaken a cell wall and then promote bacterial lysis. Okay, but because mammalian cells have no cell wall, drugs directed at this structure do not affect humans. So when we give an antibiotic, and the way that it works is it disrupts bacterial protein synthesis and disrupts the bacterial cell wall, is unique to that microbe. The next option we have for treatments is inhibition of an enzyme unique to bacteria. So this is like our sulfonamides. They are selectively toxic because they inhibit the enzyme that is critical to bacterial survival, but not to our survival. Specifically, the sulfonamides inhibit an enzyme needed to make folic acid, a compound required by all cells, both mammalian and bacterial. Because we can use folic acid from dietary sources, sulfonamides are safe for human consumption. But in contrast, bacteria must synthesize the folic acid themselves. They don't get additional exogenous folic acid. You know, it's not like they're going to be able to get it from other sources. So to meet their needs, the bacteria first take up the PABA, the para-aminobenzoic acid, which is the precursor to folic acid, and then convert the PABA into folic acid. But sulfonamides block this conversion. Because mammalian cells do not make their own folic acid, sulfonamide toxicity is limited to the microbes. So the way that it works specifically, if I give a sulfonamide drug, I am starving them of their ability to convert PABA into folic acid, and they're going to die off. The next one would be disruption of bacterial protein synthesis. So in our human cells, mammalian cells, protein synthesis is completed by our ribosomes, but bacterial and mammalian ribosomes are not identical. So we specifically make drugs that disrupt function of one but not the other. As a result, we can impair protein synthesis in bacteria, but leaving our other cells alone. So even that slide right there is a lot of different things. It goes back to our chemistry and our microbiology days. It's a good review to understand how the antibiotics and these drugs that we're using are going to work to kill off the organism. Antibiotics, or excuse me, microorganisms like this, bacteria, very, very, very wildly amongst each other. And so we typically will classify by susceptible organism into groups. So they use classification by the susceptible organism, or we can classify them by their mechanism of action. Susceptible organisms, when we say things like gram-positive cocci, gram-negative anaerobes, all of those things, right? So the book goes through and talks about that. In your book, in chapter 70, table 70.1, they do help give you a nice table that shows this, that if we are talking about antibacterial drugs by susceptible organisms, so they say gram-positive cocci and gram-positive bacilli, and then they go on to specify that you could have a penicillin or a vancomycin, etc. So that's one nice way to see that. It goes down even further into your antivirals or antifungal drugs. And then they give you 70.2. That table classifies them by mechanism of action. I really like this table. It's very helpful. And I think it's something that even I have referred to back in practice along through the years, just to really remember my antibiotics and what it is that I'm doing. So table 70.2 talks about if we look at drugs that work by inhibiting cell wall synthesis, okay? Those are our penicillins, cephalosporins, imipenem, vancomycin, caspofungin. Then we have drugs that disrupt the cell membrane, amphotericin B, daptomycin, itraconazole. So I'm not going to go through and read all of those, but this is a really great table to know where it's at in your book, especially when we're talking about antibiotic and what goes into what, okay? So to kind of review, what are all these different mechanisms of action? Okay. If we have drugs that inhibit the bacterial cell wall synthesis or activate an enzyme that disrupts the cell wall, those would be drugs then that weaken the cell wall and promote lysis and death. If we say that we have a drug that increases cell membrane permeability, then that means that these drugs increase the permeability of cell membranes, causing leakage of intracellular material. So both of those are messing with the membrane or the wall, but they work differently. So a penicillin inhibits bacterial cell wall synthesis, but amphotericin B increases cell membrane permeability so that the content leaks out and the cell dies. As an example, drugs that cause lethal inhibition of bacterial protein synthesis. These are something that the aminoglycosides do. They're the only ones in that group. We don't understand why inhibition of the protein synthesis results in cell death, but it does. Then we have drugs that cause non-lethal inhibition of protein synthesis. So these drugs, like the tetracyclines, inhibit bacterial protein synthesis, but these agents only slow microbial growth. They don't actually kill the bacteria at clinically achievable concentrations. Then we have drugs that inhibit bacterial synthesis of their DNA and RNA, or they just disrupt the DNA function. Okay, this is like ciprofloxacin, the fluoroquinolones. They would inhibit synthesis of the DNA or RNA by directly binding to nucleic acids or by interacting with enzymes required for nucleic acid synthesis. They disrupt the function of the cell, and the cell then dies, and we get rid of the bacteria. Then we have drugs that are antimetabolites and drugs that suppress viral replication. We'll go through those further down the side. Okay. One of the really interesting things is that Laney's only gives a very small section, if you will, to this, one paragraph. But I'm going to make a unique slide for this because I think it's something that you're going to hear a lot in practice. We talk about it all the time, and yet Laney's gives it very little discussion. Okay. Bactericidal versus bacteriostatic. And I want you guys to understand this and have this in your brain for clinical practice. You're going to really sound smart when you get out there and you know what you're talking about. Okay. Bactericidal agents are directly lethal to bacteria at clinically achievable concentrations. Bacteriostatic drugs slow bacterial growth but do not cause cell death, and they kind of peter out. So when a bacteriostatic drug is used, elimination of the bacteria must ultimately be accomplished by host defenses like our phagocytic cells. Okay, so this is the way I remember this, and I'm weird, I get it, but this is my thought process in my head. If I'm giving a bactericidal antibiotic, I'm thinking suicide. I'm causing the cell to actually die off. Okay, when we give them at the high enough concentration, we are actually killing the cells with the drugs. Okay, we're causing the drugs to kill themselves, is how I think it. Bactericidal, suicidal. And then bacteriostatic literally means that we put that bacteria into stasis, make it still, make it sluggish, make it weak, so that then I can come in with my macrophages and my phagocytes and I can kill it off. And it's not rapidly replicating itself and then getting out of control before I can take care of it. So you're going to hear this in practice, bactericidal versus bacteriostatic. When we give a bactericidal, we are actually directly killing the bacteria with that drug at high enough concentration of the drug. But when you give a bacteriostatic antibiotic, you are still stunning it. You're making it stasis, making it static, breaking it down. It's not working well. You're inhibiting its process from growth, while then that gives our body time to destroy it ourselves. All right, mechanisms for acquired resistance. So as we all know, we have this big, huge problem of antibiotic resistance. And so let's get into that a little bit. What are we actually talking about when we say this? You can have innate or acquired over time. Over time, an organism that has once been highly sensitive to an antibiotic may become less susceptible, or it may lose its sensitivity entirely. Resistance develops to several drugs. Okay, acquired resistance is of great concern because it can render currently effective antibiotics useless. Then we get into a real pickle clinically because we don't have good drugs to kill that bacteria anymore, and we need to go and have new antimicrobial agents created. As a rule, antibiotic resistance is associated with extended hospitalization. It causes significant morbidity and excess mortality. This is a big problem, right? This is why now in hospitals we have antibiotic resistance committees. This is why now in practice, sometimes I feel like I have to petition the Supreme Court in order to write an antibiotic. People take this very seriously, as they should. You will find in practice, if you haven't already, it does get a little annoying when you're trying to write antibiotics sometimes and you just get slammed down by the antibiotic committee. That really questions you, but it's also a good thing, right? It keeps us all in check. Two of the ones that they talk about coming up in the chapter specifically is MRSA and C. diff. But let's kind of go through the highly resistant bacteria. Okay, real quick. There's no such thing as real quick in pharm, I know. Okay, Enterococcus faecium. Okay, the Enterococcus drug, it's not good to have a culture come back with Enterococcus. They're highly resistant. They don't work anymore to ampicillin, linezolid, daptomycin, dalfopristin, and aminoglycosides. We have to use other different drugs sometimes, okay? We know that the mechanism of the resistance is listed like in your table 70.3. Then we went to Staph aureus, Enterobacter, Klebsiella, Pseudomonas, Acinetobacter, and Clostridioides difficile. Remember, when we talk about antibiotic resistance, it's the microbe or the microorganism that's resistant, not you as a patient or as a person. It's not our fault. It's the bacteria that we have acquired that has become resistant. So microbes or microorganisms have 4 basic mechanisms for resisting drugs. Okay. So let's think about this. How can an antibiotic resist the drug that we're giving? 1, it can decrease the concentration of a drug at its site of action. 2, alter the structure of the drug target molecule. 3, produce a drug antagonist. And 4, cause drug inactivation. Okay, so the first thing, reducing the drug concentration at its site of action. So for most antibiotics, the site of action is intracellular. So if the microorganism can reduce the intracellular concentration of a drug, it can resist harm. 2 basic mechanisms are involved. First, the microbes can cease active uptake of the drug. An example of that's the tetracycline. Secondly, the antibiotic or the microorganism can increase active export of the drug. So that's a problem. The bacteria gets smart. Okay, so it's working to either take the drug out of the intracellular action or resisting taking up the drug to get intracellular in the first place. Alteration of drug target molecules, which are our receptors, right? So if the structure of the target molecule is altered, if our receptor is altered, resistance can result. So if the drug gets really smart, or the antibiotic, if the bacteria gets really smart, and let's say the drug that I give is looking for a blue receptor, and that's how it knows to bind to that bacteria. If the bacteria gets smart and they change the receptor to yellow, now if I give that same drug and it's looking for a blue receptor, it's not going to find the bacteria. So if the bacteria alters the target that my drug is looking for, now it's become resistant to that drug. Okay. The next one could be that it can antagonize the drug action. For example, it acquires the ability to synthesize increased quantities of that PABA. So now they're resistant to sulfonamides. The action of the sulfonamide doesn't work because the bacteria got smart and created extra things that antagonize the drug and make it not want to work. Drug inactivation. So some bacteria can resist harm by producing drug metabolizing enzymes. So for example, if you're a drug that's resistant to penicillin G, it's because the microbe or the bacteria increases its production of penicillinase. That's an enzyme that inactivates penicillin. So for example, so the example of that in my mind is like the bacteria has, a cell, and on the surface of the cell is where the penicillin would come and have that receptor and kill it. Well, the bacteria gets smart and it starts to release out into the environment outside of the cell little guards that are smart enough to go and nab the penicillin before the penicillin can act on the bacteria to kill it. So now if I know that penicillin is coming, if the bacteria gets smart, they're going to release their little penicillinase soldiers that go out there and they kill and shoot down the penicillin before it's even allowed to get in and do its job. So now the bacteria is resisting the penicillin. It's inactivating it. The next one that we know then is the New Delhi metallo-beta-lactamase 1 gene, nicely called NDM1 gene. So we've known now that this NDM1 gene is a very powerful form of beta-lactamase. And we talk about that in the next chapters. But beta-lactamases are enzymes that can inactivate drugs that have a beta-lactam ring. The form of beta-lactamase encoded by this NDM1 gene is very troublesome because it can inactivate essentially all beta-lactam antibiotics, including our penicillin, cephalosporins, and our carbapenems. Because the NDM1 gene is resistant to our carbapenems, it's also classified as carbapenem-resistant Enterobacteriaceae, CRE. Big deal. Getting a CRE infection is not good. Worst yet, the DNA segment that contains the NDM1 gene also contains genes that code for additional resistance. Okay, so it's bad. All the genes that are present on a plasmid, a piece of DNA that can easily be transferred from one bacterium to another, it's very dangerous. Bacteria that have the NDM1 gene are resistant to nearly all antibiotics except for tigecycline and colistin. Since its discovery in Klebsiella pneumoniae in 2008, the NDM1 has been found in other common enteric bacteria, E. coli, Enterobacter, and Salmonella, Citrobacter, Provincia retgeri, and Morganella. If I were to ponder that for too long, that would give me anxiety, because that makes me crazy to think of how dangerous and scary that could be in the world of medicine. Oop, I skipped my slide. There we go. All right, mechanisms by which the resistance is acquired. We can have spontaneous mutation. Spontaneous mutations produce random changes in a bacteria DNA the result is a gradual increase in resistance. First, you get the low level, and then with additional mutation, the resistance becomes greater. Or we can have conjugation, the process by which extrachromosomal DNA is transferred from one bacterium to another. To transfer resistance by conjugation, the donor organism must possess two unique DNA segments. One segment codes for the mechanism of the drug resistance, and the other segment codes for the quote-unquote sexual apparatus required for DNA transfer. Together, those two segments constitute an R factor, which is the resistance factor. Okay. Conjugation mainly takes place among our gram-negative bacteria, but it's also possible for pathogenic bacteria to acquire that resistance factor from the normal flora of the body. Because the R factors are becoming common in normal flora, the possibility of transferring resistance from our normal flora pathogen to our normal flora microbes to pathogens is of great concern. So in spontaneous mutation, the one important thing to consider is that it confers resistance to only that drug. But in spontaneous mutation, as they're able to jump from one drug to the next, it can confer multiple drug resistance. It's very worrisome. So we know, in general, the use of antibiotics promotes the emergence of drug-resistant microbes. So how do antibiotics promote resistance? So remember, we have two things we talked about, or that we have not talked about, but we're going to talk about. One, the microbes secrete compounds that are toxic to other microbes, and the microbes within a given ecologic location, such as the large intestine, compete with each other for available nutrients. So under drug-free conditions, if there's no antibiotics on board, right, the various microbes in a given region keep each other in check. Furthermore, if none of those organisms are drug resistant, the introduction of antibiotics will be equally detrimental to all members and microbes within that area, for like the large intestine, for example, and therefore will not promote the growth of any one individual microbe. But if a drug-resistant organism is present, the antibiotics will create selection pressure favoring its growth by killing off sensitive organisms. And in doing so, the drug will eliminate the toxins they produce and hence facilitate survival of the microbe that is drug resistant. So in addition to the elimination of sensitive organisms, when we eliminate those, it will remove the competition for available nutrients, thereby making conditions even more favorable for the resistant microbe to flourish. So although drug resistance is of no benefit to an organism when there are no antibiotics present, when antibiotics are introduced, they create selection pressure favoring overgrowth of microbes that are resistant. All of that being said, what they're really trying to say here is that we have normal bacteria in our body all the time. We have this normal ratio of our flora of microbes everywhere. We have microbes on our skin and our intestines and our organs, and they're perfectly kind of balanced. So what happens is as we use antibiotics through our lives, you can create this antibiotic drug resistance. And now we shift the power of the balancing act, and that drug now becomes supercharged and is going to overtake the other normal microbes in the area. So all antibiotics promote the emergence of drug-resistant organisms, but some agents are more likely to promote resistance than others. Okay? But think about that. Broad-spectrum antibiotics kill more competing organisms in that same area than do our narrow-spectrum drugs. So broad-spectrum antibiotics do the most to facilitate resistance. The more antibiotics are used, the faster drug-resistant organisms will emerge. So not only do antibiotics promote emergence of resistant pathogens, our antibiotics also can promote overgrowth of normal flora that possess mechanisms for resistance. So because a drug or an antibiotic being in use can increase resistance in normal flora, and because normal flora can transfer resistance to pathogens by conjugation, we should have every effort to not give antibiotics unless absolutely necessary. Because no matter what, when we use these drugs, which we need to use to save lives, but that automatically means that we're going to eventually get resistance to that antibiotic. Healthcare-associated infections, nosocomial infections. Because hospitals are sites of intensive antibiotic use, resident organisms can be extremely difficult to treat. So healthcare-associated infections are among the most difficult to treat, and 1 of every 20 patients will fall victim to a healthcare-associated infection. Okay, superinfection. A superinfection is defined as a new infection that appears during the course of the treatment for a primary infection. So a new superinfection can develop when the antibiotic eliminate the inhibitory influence of our normal flora and allow a second infectious microbe to flourish. A common example of that is developing vaginal candida infection in a female treated with antibiotics for UTI. Again, superinfections are more likely to happen in patients receiving broad-spectrum antibiotics. So all of this has led to the antimicrobial stewardship. And again, this is incredibly important. I joke about it sometimes, but it's not a joking matter, really. It's really important that people use antibiotics appropriately. You will learn later down the course of our program, when you're making clinical decisions, when you're seeing patients, it is this natural urge and desire, because we're there to fix, we're there to treat, we're there to solve the problem, and we don't want to do harm, and we're afraid we are going to miss something. So our natural tendency as providers and clinicians is that we want to be safe, and maybe we ought just throw an antibiotic at somebody, because what if I'm missing an infection, or what if, etc. And so that is human nature. You're going to see this later. It's very easy to want to do. We fall victim to it all the time. The other problem is that patients get it in their head that they need an antibiotic. And so sometimes just to shut them up and make them happy and just, fine, I'll give you what you want, we give them that. And that is really bad practice. And so I'm so grateful that they truly have antimicrobial stewardship, because it teaches us to really question ourselves on why we should give antibiotics, when and when we should not. And believe it or not, this even comes into play for me in hospice care. I do a lot hospice, of whether or not people even at the end of their life should get an antibiotic, because even that usage, even though the person's on their way to dying, still contributes to us as a whole using antibiotics inappropriately. Okay. Some of the other rationale or reasons behind how do we decide what drug to use, what not to do, or what not to use, is that oftentimes for when we know the common bacteria that exists with that condition, we know that there's drugs that have greater efficacy or are more direct to them. So we should use this first line drug, and we want to be narrow when narrow is appropriate. Okay, and remember that if you give the wrong drug, so let's say, let me back that up. Let's say you'll learn this as you go on. I'm worried about hospital-acquired pneumonia, so I want to give vancomycin, Levaquin, and piperacillin and tazobactam. Okay, so I just want to hit them with every possible thing because they're sick as snot and they're going to the ICU. Okay, great. But as you get susceptibilities back, as you get a sputum culture back, as you whatever, we back off on the drugs that are useless, right? So if we identify an organism that is a certain kind that's not going to respond to the drug we're giving, don't just keep giving it because they were so sick. So it can feel weird sometimes to be like, they're still so sick of the ICU and they were on 3 antibiotics, but we taper it back and tailor it to just 1. But that's the most appropriate because we're using the true drug that's going to be the most effective. Okay. In your table 70.5, it's a really big table, but it literally goes through and talks about practically, I swear, every organism, first drug of choice, and then alternatives. And they break it up by like gram-positive cocci, gram-negative cocci, gram-positive bacilli, gram-negative bacilli, etc. And so this is something that's really helpful. Like if you guys want to print this off and carry it with you to clinicals, it would probably be worth your time. It's a nice little big table that'll tell you. Okay. So then your book also goes into making sure that you understand identifying the infecting organisms important. There are times when we can't, and there's times when it doesn't make sense and it's not cost effective. For example, in primary care, sometimes people just treat without sending things off for culture. But we want to try to match the drug with the bug is the way that they, the slang way that we say that. So then we also have the technique of getting gram stains. So you send it to the lab and they take the body fluid or whatever that is, the swab, the whatever, and they usually use PCR, which is our polymerase chain reaction, because that can detect even the subtlest, slightest bacteria or viruses. Okay, so they do that, and you have to so there's the gram stain versus like the PCR. Sorry, I got interrupted in my speaking. So let me get back on my train of thought. The gram stain versus the PCR. Gram stain's been around forever and a day. It's still very good. It's great. But PCR is wonderful because you can have it takes a smaller amount to be tested and it can detect even the lowest levels of bacteria and viruses. Not all of the microbes can be identified yet with PCR, but if it's available to be done, it is what we would prefer to do. So you may hear this someday in practice when they're like, did you send the C. diff PCR? So why does that matter? Because what they're saying is if that's available by PCR, let's do it because it will detect even the slightest amount. PCR tests are both more specific and more sensitive than a gram stain. So finding out what the drug is susceptible to means that sensitivity testing has to be done. We don't do this for things that aren't really considered typically right now resistant agents. But if they're things like MRSA, for example, we should test to see what it's most sensitive to. And when you're testing for susceptibility, that's done in the lab. We trust them there. You're going to get a result as a practitioner of what the drugs are, or what drugs are sensitive to the microbe that you have. We also have other things at play here when we're talking about the use of antibiotics, one of which is our host defenses, right? So if we have our immune system and our phagocytic cells and we're in good health, we probably have good host defense system. So we use those as well as the antimicrobial. So we still have to have our own defense system to be at play when we're doing or treating bacteria in our body, okay? In most cases, the drugs that we're using aren't curing, quote unquote, the infection on their own. So what do we mean by that? Not a lot of drugs are bactericidal. A lot of drugs are bacteriostatic. What does that mean? They stun them, they put them in stasis, they slow them down, they make them weaker, but we still have to have a good host defense system then to finish the job off and kill off that bacteria, so to speak. So the drugs we give, our antibiotic, work with our host defense system to subdue the infection. So our goal typically is not to outright kill the infective organism. Rather, our goal is to suppress its growth to the point at which the balance is now tipped in our favor and our host defenses can work. Okay, so I want to say that again because we use these words a lot in practice. We throw them around, and the words are immunocompromised or immunocompetent. Okay, and so when those words are used, what are we talking about? I really want you guys to understand that. When I say that someone is immunocompetent, what I'm saying is that they have an intact, competent immune system. So my host defenses are strong, they're intact, and they should work in concert with my antibiotics. So now I can give bacteriostatic drugs. I have a lot more ways that I can harm those antibiotics. A lot more ways, or not the antibiotics, the bacteria, a lot more ways to harm the bacteria. But if I am a person and my host defenses are down and I am immunocompromised, now we're in a pickle because the majority of the drugs we have tend to be more towards bacteriostatic. Remember, they're stunning, they're slowing, they're making the bacteria weak. But then they rely on an immune system to come in and take care of the rest. They want our immune system to come in and sweep up the aftermath, so to speak. But if I am immunocompromised, now we have a big problem. So if I have AIDS, if I have HIV, if I have poorly controlled diabetes, if I've just received a crap ton of chemotherapy and my immune system is in the gutter, now we have a problem. When treating the immunocompromised host, our only hope lies with drugs that are rapidly bactericidal, and sometimes even that's not enough. That's why someone who's immunocompromised is at risk of dying, because we don't have great drugs to give that are bactericidal. That's also why this is a huge problem for antibiotic resistance. Okay, we create these drugs and eventually the antibiotic resistance is going to be there. Eventually the microbes get smart and eventually they win, so to speak, and then we have problems. So when we have immunocompromised people out there in our community, we have to make sure that we are not contributing to the problem of people being antibiotic resistant, right? This is a really big problem in healthcare. There is nothing worse than watching somebody die from sepsis because we just don't have enough bactericidal drugs and their immune system was shot. Okay, so I know that Lainey's doesn't talk about this as much as I am, but this is a really important concept to remember. Bactericidal drugs are suicidal. If I give that drug, it is actually killing the bacteria directly. The bacteria is dying itself. That's auto-imploding. Suicidal. Okay? It's dead, it's dying. Death of the bacteria and bactericidal. But if I give bacteriostatic drugs, I have to have a competent immune system to work in concert with that drug to actually get the death of the bacteria and to get it out of the system. If I have a faulty immune system, if I'm immunocompromised, I have to have bactericidal drugs, and we don't have that many. And a lot of them are becoming resistant. So if I'm an immunocompromised patient and I get a highly resistant drug, a highly resistant microorganism and highly resistant infection, I could be really at risk for death. Okay. And the other factors that we have to take into consideration is your site of infection. In order to actually deliver the antibiotic or the antimicrobial drug to the area to work against the microbe, I have to have decent blood supply to get there. And if you don't, then we have an issue. So if you think of things like meningitis, in order for us to actually kill the drugs in the meninges or in the brain, the cerebral spinal fluid, we have to find drugs that are able to cross the blood-brain barrier. So now we're limited on what antibiotics we have, as an example. Another one is endocarditis, because the bacterial vegetations in the valve or in the heart are difficult to penetrate. The other thing could be an abscess. So if you have a big pocket of purulent material, you almost always have to have some kind of surgical incision and drainage, because in order to even get to the site where the antibiotics or antimicrobial would work, will be impeded by the pus, as an example. So you have to consider the site of infection and the blood supply. The other thing about that too is like a diabetic toe infection. If they have pretty severe peripheral vascular disease and really limited blood flow to the toe, and that tissue gets infected, oftentimes all we have left to consider is amputation, because without the amputation, there's no way we're going to get the antibiotics to the area. The other thing that are really important to consider as well is if you have foreign material in your body. So if you have a pacemaker, or you have an artificial knee or an artificial hip, and now you get infections around that area, that can be really difficult, because phagocytes react to these objects and attempt to destroy them. So because of that, the phagocytes are less able to attack the bacteria and thereby allow microbes to flourish along those areas. And I always tell patients that the microorganism can be really sticky and likes to stick to the surface of those artificial pieces in our body, and can be really hard to get rid of completely. Oftentimes we end up having to remove a foreign body, because without taking out that hardware, we're never going to totally get rid of the infection, as one example. Other things to consider when we're talking about antimicrobials in general, one of which is a previous allergic reaction. We hear about this all the time about penicillin allergy. It's the most common drug or antimicrobial class to have an allergy to. As a rule, patients with a history of a severe allergy to penicillin should never receive them again. The exception is that if you have a life-threatening infection and there's no suitable alternative. Some of the other classes like sulfonamides and erythromycin are associated with high allergic responses. However, really, truly anaphylactic reactions are more rare than we think. Skin testing is also available to see if you're truly allergic to penicillin or if it just gives you bad side effects. Genetic factors play a role in the interaction between the host and the antimicrobial. Your genetic heritage makes a difference. So whether or not you're able to use a certain drug the right way, for example, some antibiotics like the sulfonamides can cause hemolysis in patients who have red blood cells that are deficient in the G6PD. That's just because of their genetic makeup. Genetic factors can also affect the rate of metabolism. For example, the hepatic activation of isoniazid is rapid in some people and slow in others, so that could affect how you tolerate that drug and whether or not it's helpful or not. Other factor is the dosage and duration of treatment. Success requires that an antibiotic be present at the site of the infection in an effective concentration for a sufficient amount of time, right? Because again, very few drugs are bactericidal. A lot of them are bacteriostatic, and we allow the host to work on it and get rid of the infection. So I need to keep the drug concentration at the maximum efficient level for a specific duration of time to allow the body time to get rid of it. So in other words, it doesn't do me any good to give certain drugs for just 2 days because we know the body's going to need longer to eat up, quote unquote, the bacteria. We call that the MIC, minimal inhibitory concentration. Okay. Drug levels 4 to 8 times the MIC are often desirable. We really want to make sure we're saturating that bacteria as much as we need to in with that antimicrobial. There's a point in your book that tells you specifically that it's imperative that antibiotics not be discontinued prematurely. Patients should be instructed to take their medications for the entire prescribed course, even when their symptoms subside before the course has been completed. Not utilizing the antibiotics as they're prescribed helps contribute to resistance. Only under certain circumstances should we consider using multiple antimicrobials at once. Oftentimes, this is a hospitalized patient who's very ill. Sometimes we do need to use antibiotics in combination or antimicrobials together for a specific reason. Okay, an example of that is we use like trimethoprim plus sulfamethoxazole, which is our Bactrim. Those are specifically given together, and they have to be given together to get the effect that we're looking for. It is possible to have a mixed anaerobe. So it is possible that maybe you get a urine culture back and the sensitivities and the culture, the culture, not the sensitivity, show the presence of 2 distinct bacteria. So they do need 2 distinct antibiotics, one to treat one and one to treat the other. Those situations do occur. They're not as common in the general public. Those are typically sick, medically complex people that are more prone to get those situations. Sometimes they purposely would have a reason to give a drug in combination because of the toxicity of one drug, etc. Those are pretty specific things. There's a disadvantages to having multiple antibiotics on board. They increase the risk for toxic or allergic reactions. You can have the possible antagonism of antimicrobial effects where they're actually doing more harm because they're canceling each other out. They're really giving you increased risk for superinfection. They're increasing your drug-resistant bacteria odds, and they're more expensive. Okay. The other point to consider in general when we're talking about antimicrobials is that there's a difference between the terminology of prophylactic and empiric. Okay? Prophylaxis means we give it in prevention of an anticipated thing. So if someone has a prosthetic joint and they have to take a prophylactic antibiotic before they go to the dentist to get a procedure done, okay, what we're saying is we are going to put you at risk to be put into an environment that puts you at risk for an infection, and because you have this certain condition or this certain situation, we're prophylactically treating you. We think you're really at risk for getting something, and so we're trying to prevent that. So we prophylactically treat you. Okay. Empiric antibiotics is when we're using our best guess to treat a known infection, right? So if you have a UTI and I know in our area the most common thing is an E. coli, so I'm treating you with a cephalosporin empirically until I get the culture back and know exactly what drug is. That's empiric treatment. Prophylactic treatment is you don't have an infection yet and I want to keep it that way, so I'm giving you an antibiotic prophylactically. Okay. We use prophylaxis in certain things, but we way overuse it, and so now antibiotic stewardship has really helped with that. A lot of times you get a prophylactic antibiotic before surgery. We know that rates of surgical complications go down when someone gets ANSEF within 30 minutes of the surgical incision for XYZ procedure. That's appropriate. We have study in the science to back that. That's okay. One of the examples your book gives is cardiac surgery, peripheral vascular surgery, orthopedic surgery, or surgery on the GI tract. Women undergoing a hysterectomy maybe get it, or sometimes an emergent C-section, they're going to hang it because it's kind of a emergent situation. Some things the book talks about, like if you have lacerations from an animal bite, even though you haven't had an infection yet, it's almost 100% rate that you're going to get one because of what you've been exposed to. So we go ahead and start the antibiotics. Book talks a little bit about neutropenia. Of course, there are some things that in some situations when you're under HIV treatment or certain things, when you have to be like on a prolonged antibiotic regimen course, maybe you end up on an antifungal or an antiviral because they know oftentimes you can have a co-infection with that. And so they're prophylactically treating that, trying to keep it at bay from developing and being a problem. There are some situations such as recurrent urinary tract infections, and so they keep you on an antibiotic prophylactically to try to prevent recurrence. Those are very specific situations, and it is the exception, it's not the rule. Misuse of antimicrobials definitely occurs when you have a viral infection and we treat you with antibiotics. It happened in the 80s, 90s, and the early 2000s. A lot. People were just like, you had a sniffles and a head cold and they threw antibiotics at you that were completely pointless because you were sick with a virus and not a bacterial infection. We don't want to do that. We don't throw antibiotics at fevers, even if their fever is 103. It doesn't mean that they're infected with a bacteria. It could be a lot of other factors, so we don't just throw it at that. And then remember that surgical procedures are often necessary to give the antibiotics a chance to work. So that is the chapter 70. As we proceed through the rest of the chapters, I really want you guys to utilize the osmosis and how they help you review the classes of medications as well. I think that'll be very helpful. For the purpose of studying for this chapter, some of the concepts that I've really emphasized on, I want you to be comfortable with. I want this to be the groundwork and this understanding that you do have of these topics so that we can build as we go through the next chapters. All right, thanks.